This paper is first of its kind towards customization of IOL surgery to get better quality and quantity of vision. I have no financial disclosure to make. Purpose of this study is to evaluate effect of custom-made IOL. Aim of the study is to find out the effect of neutralizing spherical aberrations and asphericity of the cornea separately and which one of is more effective. I have taken help of biotech company India from Ahmedabad to make these IOLs. These IOLs are made in two groups, one based on asphericity of the cornea and other based on spherical aberration of the cornea. Topography of both surfaces of IOLs are checked personally by me so that no internal aberrations are left out. IOL power map from center to periphery is done and printed on each IOL label. In this slide, you see power map from center to the periphery, and the difference in the power between center and periphery will give us various values of spherical aberrations or asphericity correcting ability of that IOL. Two groups of patients are selected. Group 1 has spherical aberration correcting IOL and Group 2 has asphericity correcting IOL. Each Q value correcting IOL are labeled as RCQ1 to RCQ5 depending upon their ability to correct the Q value, and similarly a spherical aberration correcting IOL are labeled as RC00 to RC05. All are modified C-loop design. In this slide, you see how spherical aberration changes with the age. Normal cornea is prolate, bringing the peripheral rays in front of the fovea. The distance between the foveal focus and a marginal focus is known as a spherical aberration, as you see in this slide. If it is in front into the vitreous, it is prolate or positive spherical aberrations, and if it is behind fovea, it is negative or oblate cornea. We must understand the relation between the Q value and a spherical aberration. In this graph, they are inversely proportionate. However, at around 0.2 value, both almost remains the same. One should not get confused with each other. Presently, all the IOLs in the market are spherical aberration based. The spherical aberrations are presently understood under 4 headings, as in this slide. In short, you can understand a positive or a prolate and a negative or an oblate cornea in the shape of an egg. Spherical aberrations or Q value can be measured for each patient with one of these 3 equipments. I studied 1000 patients of Indian eyes for spherical aberrations. 70% of the patients fall between plus 0.27 to plus 0.35, that is, they are prolate. For getting very good quality and a quantity of vision, we must neutralize asphericity of the cornea or spherical aberration. So, it improves the quality and quantity of vision. It also eliminates halos and night vision problem. It improves contrast sensitivity of the patient, and it increases the depth of focus so that near vision add in monofocal IOL is reduced. Purpose of the 2 group is to find out which one of the 2 group performs better. For this study, in both the groups, I selected the patients between the age of 40 and 60 who do not have any other ocular pathology which can affect the performance of the IOL. In short, I tried to evaluate purely the optical performance of an IOL. This is a routine like any other studies. The only difference is that topography is done with 2 different machines to avoid any error. In this slide, you have both values for spherical aberrations as well as the Q value of a same patient. In group 1, for spherical aberration based IOL, are labeled between RC00 to RC05. In this, we try to neutralize the spherical aberration of the cornea. If the spherical aberration is plus 0.3, then RC03 IOL was implanted, and if it is 0.25, then RC02 was implanted. RC01 IOL can neutralize the spherical aberrations of 0.1. RC04 can neutralize the spherical aberration of plus 0.4. Spherical aberration based IOLs were hydrophilic. I tried to undercorrect marginally spherical aberrations in all patients to get some depth of focus. In group 2, IOLs are labeled as per the Q matching ability between RCQ1 and RCQ5. They are matched nearest to the value of Q between minus 0.1 to minus 0.5. Q match IOLs are hydrophobic in nature. I have overcorrected Q value to the nearest IOL so that we can leave some amount of overcorrections in order to get some amount of depth of focus. The cataract surgery and the post-operative follow-up is routine like other surgery. The only difference is the contrast for near and distance are done at 30 days and 180 days. Near vision add is noted. Speed of reading is also noted for actual performance of IOL for near vision. In group 1, 70% of the patient achieved 6/4 vision with best correction and maintained the same vision for 6 months. All of them in this group achieved more than 6/5 vision till 6 months. 80% require an addition of plus 1.5 for near and 100% require addition of plus 2 for near. Almost all patients wanted the second eye to be done immediately as they were so happy with the results of customization of intraocular lenses. Contrast sensitivity in this group has improved by 20%. In group 2, 80% of the patients achieved 6/4 vision with best correction for distance and 100% achieved 6/5 vision or more with best correction, and same vision has been maintained for 6 months. All of them required plus 2 addition for near. To conclude this study, Q-based IOL gave slightly better distance vision than spherical aberration based. The spherical aberration based IOL gives better near vision than a Q-based IOL. Customization of intraocular lens implant surgery is going to be future of cataract surgery. The take-home message from here is that I request all of you to make this idea future of all the cataract surgery. Never correct the pseudophakic system into oblate. IOL selection for monofocal as well as the multifocal should be done with matching Q value or spherical aberration value to get excellent quality and quantity of vision for very happy patients.